It's a Northwest Lifestyle Weekend on Como News. IRG's Health Talk continues.
All right, we welcome you back for our next guest, Dr. Carlos Pineda, vascular surgeon for the Polyclinic. Today, we're discussing peripheral artery disease, and to find out more on that, let's talk to Dr. Pineda along with Shannon O'Kelly.
Dr. Pineda, welcome. How are you?
Doing great, thank you.
You work at the Polyclinic. You're a vascular surgeon. I always like our listeners to kind of get an idea what a day in the life of Dr. Pineda is like at the Polyclinic being a vascular surgeon. Tell us about your practice.
Sure. So my practice, like most vascular surgery practice, are very dynamic because in the office, I'll be seeing patients for a new consultation, seeing them for follow-ups, but I'll also be doing procedures in the office and also in the hospital. And then at the end of the day, I'm reviewing ultrasound studies, which is part of what I do.
A vascular surgeon, how do you become interested in that? And tell us about the veins and arteries and the area you work in.
Sure. So I was actually born and raised by a dad who was a surgeon.
Okay.
Grandfather's a surgeon, so the apple didn't fall that far off from the tree. So I went to medical school thinking I'm going to be a surgeon. And then when I was doing my surgical rotations as a resident, I suddenly stumbled on vascular surgery. I'd never seen anything like it. I thought it was really fascinating, really interesting. So that's how I got interested in that. Finished general surgery training, and then I did my specialty training in vascular. So let's talk a little bit about the specialty. So the specialty of vascular surgery is very unique. There was a recent article on U.S. News and World Report where they did a piece on vascular surgery. And they basically refer to us as the primary care doctors of the blood vessels. And that's actually a great description because we do diagnosis, management, treatment of conditions of the blood vessels all over the body, with the exception of the heart and the brain. So that's kind of where we fall in terms of patient care.
It's fascinating. The stuff that you folks are doing in your procedures and prevention and treatment and diagnoses. I mean, let's go back to your grandfather. I'm sure your grandfather back in the day was what you call a general surgeon, did everything. And now these subspecialties and you being a vascular surgeon working with arteries and veins. Tell our listeners the difference between artery, vein. Maybe walk us through Anatomy 101. Let's talk about the circulatory system itself.
Yeah, no, that's a great question because many people use these terms interchangeably. And arteries and veins are very different in terms of structure and function. So let's start with the arteries. So the arteries carry the blood from the heart down to the feet, down to the organs and tissues. And the blood is deposited in these tissues. We drop off the oxygen, and then we carry the oxygen back in our blood. We carry the blood back to our heart through the veins. Arteries are thick-walled structures that pulsate. And veins, on the other hand, are thin-walled structures with valves on the inside that only allow blood flow to go in one direction. So that's why they're very different in terms of their anatomy and their function.
And the reason, the difference, the anatomy and function, you described it beautifully, by the way, but just, again, these arteries are pressurized. I don't think people appreciate how much pressure your heart is pumping when you push blood into your system through those arteries. So they're thicker to take that pressure, where a vein basically is pretty much a passive movement back towards the heart, hence the valves. Tell us about the valves, particularly in the veins, as you get to the lower extremities and how sometimes they fail or can fail.
Right, exactly. So the blood flow in the veins tends to be a little bit more passive. They're relying on the fact that as we walk and we move around, our calf muscles are pushing onto the veins and pushing the blood back up. These valves are only supposed to allow the blood to go back up, not to go back down. However, under certain conditions, let's say, for example, in a family where the varicose veins is a genetic component of that particular group, these valves are not closing completely, and in folks that spend a lot of time on their feet, suddenly you have a column of fluid that starts at your heart, goes all the way down to the floor, so you have sort of a pressure gradient going down, and if these valves aren't working, then you tend to pool blood in your legs. That's why we call this condition leaky valves, and this is what eventually can lead to the formation of varicose veins, a bunch of different symptoms, swelling, discoloration, etc.
And in the musculoskeletal world that I, as a physical therapist, live in, when I see a patient that's post-op and is non-weight bearing in that leg, a lot of times that leg becomes swollen, basically, because, again, you described it, they're not weight bearing, they're not using the muscle pump, so the fluid pulls down there. We're going to get back here in a few minutes, or a few seconds, to talk about some treatment, but thank you so much. Great job. I'm looking forward to coming back.
Our conversation with Dr. Carlos Pineda talking about peripheral artery disease continues right after this timeout on Como.
It's a Northwest Lifestyle Weekend on Como News. Here's Tom Hudler and Shannon O'Kelly with more IRG Health Talk.
We're back with more with Dr. Carlos Pineda and Shannon O'Kelly. Peripheral artery disease. Here's the latest on that with Shannon and Dr. Pineda.
Dr. Pineda, again, great job setting this up. I know we're on radio. I always say this. We're talking anatomy, but I can visualize arteries and veins. Let's talk about some diagnoses you might see. Let's talk about particularly peripheral artery disease. We hear about it, we read about it, but I'm not sure we all know what it is.
Sure. So peripheral arterial disease, or PAD, refers to a condition of the blood vessels where there's hardening of the arteries, and this is due to the formation of plaque. Now, plaque is formed of cholesterol and also fatty deposits that over time can cause narrowings and blockages. Now, this can happen anywhere in the body, but we frequently talk about PAD in relation to what happens to the legs. So, for example, folks that get narrowings can have no symptoms at all, or they can have symptoms. In the more severe form, we have what's called critical limb ischemia or chronic limb-threatening ischemia. And this is more severe blockages. The tissues are starved. They're not getting enough oxygen. And you start seeing more severe conditions such as pain at rest. So these are folks that are asleep at night. Suddenly they wake up with severe pain in the balls of their feet. And the only way you can make it better is by dangling the feet off the side of the bed, or they stand up and stomp out the pain. And the more severe form is when folks start having ulcers. They can't heal. They start having gangrene. And this is portends a very poor prognosis because if left untreated, their likelihood of getting a major amputation, we're not talking toes, we're talking losing the foot, losing the leg, is very high at 2 years.
So this basically what happens here, just to kind of summarize this, if your body is depositing fat in your arteries, that fat is going to form plaques. It becomes hard. It decreases the size of the lumen or the blood flow. So if you diagnose this, how do you diagnose this in the body? Is this a total body scan? Do you inject something in here? How do you know where the blockage is?
So first things first, and this is true for all of medicine, you got to get a good history. You got to know what the patient's medical history is, if they have the risk factors, what medications they're on, and then you do your physical exam. And that's the nice thing about is examining the vascular system. You look at their feet, you look at their color, you feel for warmth, you feel for pulses. No pulses? Guess what? There's got to be a blockage somewhere. And then you kind of direct your imaging studies based on what you find. So you don't put a patient through a whole body scan. You just target your analysis to what you're looking for. So, for example, most of the time we'll start with an ultrasound, and we'll start with non-invasive testing. And then depending on if we're looking for another part of the body, then fine, we'll get a CT scan or an MRI. But it'll kind of depend on what we're looking for.
And what kind of treatments are available?
One of the first things we do, risk factor modification. We counsel our patients to stop smoking if they do. I prescribe nicotine patches, gum, the medications, all that stuff. Make sure that their diabetes is well controlled, that they're taking their blood pressure medicine. And then that's one part of it, increasing activity, watching their diet. And then if they still need some sort of intervention, as a vascular surgeon, I'm equipped to do minimally invasive treatments such as angiograms, putting a balloon in, such as an angioplasty, putting in stents depending on where the lesions are, and also traditional open surgery where we would do a bypass or actually physically removing the plaque from the body.
Wow, again, great stuff. Thank you for your time today.
Thank you for having me.
Shannon, that was Dr. Carlos Pineda, peripheral artery disease, and something that, vascular medicine is something that we don't talk about a whole lot here, but certainly something that a lot of people need to be aware of.
Again, one of those things you really don't think about, your circulation, how important it is, but thankfully we have people like Dr. Pineda that are out there helping us.
More information, polyclinic.com. Final segment of the show coming up after this time out on Como.